Hello, I'm Dr. Sloan Manning. I'm from the University of North Carolina at Chapel Hill. I co-direct the Mood Disorders Clinic at the Family Medicine Residency Program in Greensboro, North Carolina.
The following audio is part of a certified educational activity titled Recognition and Treatment of Bipolar Depression, exploring a patient's journey from diagnosis to treatment. Access the entire activity and complete the post-test at www.peerviewpress.com/BWE. Downloadable slides and practice aids are also available.
Today I want to share a story with you about a patient in my practice who has bipolar disorder but was originally misdiagnosed with major depressive disorder. This is actually a pretty common state of affairs in outpatient psychiatry and in primary care because of the nature of the illness. And I'd like to tell you the story today of a particularly instructive patient. That patient's name is Salley. So bipolar disorder, as many of you know, is a neuropsychiatric condition that's quite severe. It's characterized by fluctuations in mood and energy levels. It consists of manic or hypomanic episodes, usually with recurring major depressive episodes. Although the age of onset for bipolar disorder is typically set at 21, people who first start experiencing the illness usually begin in their teens with an index episode that's usually depression. So you usually experience a series of major depressions before you have your first manic episode and you can be formally diagnosed as having bipolar disorder. It's a challenge to diagnose in primary care and in psychiatry because depressions outnumber manic episodes, and also it's just hard to think in differential ways sometimes when the patient is presenting with depression, but you have to decide what kind of depression you're looking at. There are multiple mood states, there's a lot of comorbidities. So when Salley first presented to my clinic, she was 26 years old and had been experiencing recurring depression since about age 13. She was a political science major. Within a few weeks of graduating, she had a minor in art. She was graduating from one of our local universities in Greensboro. She was referred to me by a therapist that she had been seeing through the Department of Psychology at the university. And I'll never forget the day that she walked into my office because she was immediately engaging me in conversation. She was not hard to talk to. She's very intelligent, very bright, looking very happy, rather chatty. As a matter of fact, I became so involved in the friendly conversation that I had to remind myself that we had some business at hand. When I got her to go ahead and tell me a little bit about her college experience, she said, well, I'm on the 8-year plan. And I said, well, I've heard about the 5-year plan, but I don't know about the 8-year plan. Tell me about that. She said, well, I've stopped and started college 3 times. I've had 5 changes in my major. I started with history, then I went to philosophy, elementary education, finally decided on political science, but I kept my art minor. So I said, we have to talk about why you're here. What were you hoping to gain from our conversation, from our meeting today? And at that point, Salley broke into tears. I mean, a sobbing mess that we, took several Kleenexes. It took a couple of minutes for her to compose herself. And she said, I've been dealing with depression my whole life. Medicines have never really helped me, but my therapist thinks I really need to give medicines another try. What is the typical story of someone who has bipolar disorder? How does it differ? How do the stories of a major depressive illness differ from the story of a bipolar illness? And in medicine, at least, we learned initially the phrase, all that wheezes is not asthma. I mean, wheezing can be asthma, but it also can be pulmonary edema and another series of diagnoses. In this case, all that is depression is not major depressive disorder. So if you're presenting with depression and you're looking at a differential diagnosis of depression, the underlying depressive diagnosis might be major depressive disorder, could be bipolar disorder, could be a premenstrual dysphoric disorder or a substance use mood disorder, or maybe a mood disorder from another general medical condition like stroke or thyroid or some other brain injury, or it could be a chronic dysthymic disorder. And the DSM-5 criteria for a major depressive disorder are the same as the DSM-4 TR criteria for a major depressive disorder. It involves 2 weeks of persistent depressed mood or anhedonia with enough other symptoms to make 5 total symptoms that are clinically impairing and that are not due to anything else. And so I think all of us are familiar with the diagnosis for major depression. It turns out that the criteria for a bipolar depression and the criteria for a major depressive disorder in terms of a major depressive episode are not different. So bipolar disorder is often misdiagnosed as depression. There was a very well-known study published 10 or 15 years ago where a series of individuals with bipolar disorder were asked the question in a survey, how long did it take you to get properly diagnosed with bipolar disorder? And the average time to be properly diagnosed was about 10 years. And most people were misdiagnosed with major depression initially, and the average number of healthcare professionals needed to make the diagnosis was between 3 and 4. There have been a few studies. Actually, we were one of the first to publish such a study back in the 1990s about depression presenting in primary care settings. And in our study, and that looked at what percentage of people with depression in primary care have a bipolar disorder, we found about 25, 26%, and that study has been replicated a number of different times. Now, what you're looking for to make the differential diagnosis is a manic episode. Of course, it's a distinct period of abnormal or persistently elevated or irritable mood. People become expansive in their mood or extremely irritable. Psychosis is not uncommon. Getting in the hospital is not uncommon. So you're looking for a period of time for a manic episode when your energy and mood is someplace very different, elated, energetic, or severely irritable, and the wheels are starting to fall off of your life because you can't get anything done. A hypomanic episode is a milder manic episode. They don't last as long typically. 4 days is required for the diagnosis, but you're looking at the same sorts of symptoms. You're just looking for a milder, shorter duration of the manic symptoms. One of the most important things that you can learn about manic and depressive episodes in bipolar disorder is that it's not necessary to be either manic or depressed. In the DSM-5, you can have manic episodes that are mixed with depressive features, and you can have depressed episodes that are mixed with manic features. And so the mixed features specifier is a particularly important thing to recognize in terms of what symptoms people have. So what makes a diagnosis? Any diagnosis. What's in a diagnosis? Actually, there are 5 elements of a diagnosis. The first element is phenomenology, which is the symptoms that you see. The second element is the longitudinal course of the illness. How did it begin? How did it change over time? The third element of diagnosis is pedigree or family history. Is it inheritable? Is there a genetic connection? The fourth element of diagnosis is treatment response, because different types of illnesses do respond differentially to different kinds of treatment. And the fifth category of evidence or classification for a diagnosis is biologic markers. Now, we don't have biologic markers for bipolar disorder or major depressive disorder really yet in a very clinically useful fashion, but it's getting there, but we don't have that yet. So we were talking about Salley, right? And Sally's story sounds like this. She had her first major depressive episode at about age 13. For bipolar women, this is not uncommon at all because there's something about menarche, or beginning the reproductive cycle that opens the door for mood issues in women. And when I asked her to tell me about the nature, symptoms in her depressive episodes, first of all, she said, I've had so many episodes, I don't know how many episodes I've had. So TNTC, too numerous to count. Some of the episodes were very agitated, painfully agitated, and there were some cutting behaviors during those agitated depressions. Other depressions were more atypical: overeating, oversleeping, arms and legs feeling like lead, rejection, sensitivity, reaction to positive stimuli, except that when the stimulus is gone, the depression comes right back. She did one previous suicide attempt in the past. It was an overdose at age 16 after the breakup with her girlfriend. She was treated at the emergency department, referred to a therapist. Interestingly, when we talked about her previous suicide attempt, she said, I have an anti-suicide pact with a close friend of mine. And I said, really? And she said, yeah, I'm really wanting to be different from the rest of my family. I want to live. But there have been a lot of deaths in my family. So a little more history for Salley. She's graduating college in a couple of weeks, but she has no career plans. Well, she waits tables at a very upscale restaurant in the area. She had hopes of becoming a sommelier, but she said, I don't do alcohol well. Bing! Don't miss that. My question after that was, tell me about not doing alcohol well. She has a history of binge drinking, had one DUI in the past. She said, I finally decided that alcohol was a dead end for me, no pun intended. But I mean, look at my family history. She smokes cannabis socially, about twice a month, at a party a couple of times a month. Really produces anxiety and some true paranoia if she goes beyond just a little social sort of participation in terms of cannabis. And this is a general rule that you should understand, that everyone should understand about mood disorders and bipolar disorders in particular. When you mix bipolar disorder with substance use disorders, you release the beast. So I asked her about significant relationships, and particularly intimate significant relationships. And Salley is sexually ambivalent. She describes herself as having 8 total sexual partners in her life, some male, some female. When I ask her to place herself in an LGBTQ category, she demurs. She's like, yeah, no thanks. I'm not really interested in sex right now. And I took that to mean, let's move on, and we did. So she gets an exercise bug now and then. Again, she goes sometimes in these depressions into very, very, sort of leaden paralysis. And what she said was, well, I remember one summer after my sophomore year at school when my interest in exercise and art were just off the scale. And I said, well, off the scale, what do you mean? Well, I spent a lot of money on art supplies. I mean, a lot of money. I was exercising constantly. I only needed 1 or 2 hours of sleep at night. I was calling people up in the middle of the night and demanding that they come over and see my latest art project, my latest ceramic or paint or whatever. And again, I'm calling people at 3 a.m. and saying, I can't believe you don't want to come over and see what I've done. It's beautiful. Or I'm heading to the gym and it's 3 a.m. and I want you to come with me. And what? What do you mean you won't come with me? I can't believe this. She also said that her head was so full of thoughts that she fantasized about drilling a hole in her head to let all of the excess thinking out. And so that to me was, whoa. We've got decreased need for sleep, we've got boundless energy, we've got some behaviors that are negative in consequence, and I'm thinking, what's going on? And she even said that she broke that cycle by going into a drinking binge. So Salley's talked about her family history a couple of times, remember? So let's go to Salley's family history. A maternal grandmother who was institutionalized and actually ultimately treated with a frontal lobotomy. A maternal aunt with serious depression who was treated with antidepressants, who got bad enough ill to be treated with ECT, electroconvulsive therapy, shock therapy, who died by suicide. Her mother, severe postpartum depression, alcoholism, with eventually a formal diagnosis of bipolar 1. An older brother with ADHD, substance use disorders, We don't know where he is. He hasn't been seen in a while. And a younger brother who was alcoholic and died suicide by hanging. That's a serious family history. One of the things that differentiates unipolar major depressive disorder from bipolar disorder is that bipolar disorder, as a more heritable psychiatric illness, the family histories look sicker. So Sally's been treated a couple of times. Again, when she came in, antidepressants have never worked for me, but my therapist really wanted me to try one more time because my depression was getting more serious. She's tried several. Nothing's really helped her except one, antidepressants that she remembers taking, where in about a week she felt like she had been cured of her depression. She was active, talkative, she was back into exercise and practicing for half marathons, and that lasted about 6 weeks, and then the benefit was gone. She crashed back into the depression. And no matter what her provider did with a dose of the antidepressant, they could not recreate her recovery. Well, what happened in that situation was most likely that the antidepressant triggered a hypomania that looked like relief from her major depression, but in fact was switching her, it was a switch, into a hypomanic episode. She's never had a trial of a mood stabilizer or an atypical antipsychotic. So I don't know about you, but I measure depression. So in my practice, we use the PHQ-9, and we gave Sally the PHQ-9, and she scored 20 out of 27 with nothing for suicidal ideation, which is nice, and basically extremely difficult for the 10th question. So she's got a severe depression going on with some anxiety on the GAD-7, which is the instrument we use for measuring anxiety symptoms. She scores about an 8. When we use a screener for bipolar disorder, which is the CD3.0, she's positive on both the STEM questions for expansive mood and irritable mood, and she endorses every one of the 9 manic symptoms. So she would score at a very high risk for bipolar disorder. So the screener is backing up what I've already heard already. So we're really looking for associated features. We got some blood work, comp panel, lipid panel, TSH, CBC, urine analysis. All of that was normal. So as we might have mentioned in the earlier part, or you've surmised by now, bipolar disorder comes mixed with a lot of other things. It's very rarely pure in terms of other DSM-5 diagnoses. Most people have comorbidity on axis 1, usually substance use disorders, but anxiety disorders such as generalized anxiety, panic disorder, PTSD, not uncommon at all. You'll find people with bipolar disorder with OCD. You'll find lots and lots of comorbidities. So once you find one thing, you're more likely to find others. And the complete assessment of somebody like Sally with bipolar disorder, you're going to assess for depression, anxiety, mania, substance use. You want to make sure that you know who you are engaged with and treating before you move on. Bipolar disorder is associated with higher rates of diabetes, with migraine, with the tendency toward chronic pain disorders, with cardiovascular disease. So in order to truly treat someone like Sally, you have to be looking for metabolic issues and the mood issues, and you might be, co-managing, a migraine disorder. And if she has a strong family history of coronary artery disease, you want to make sure you factor in her bipolar disorder as a risk factor for her coronary artery disease. So you're establishing the diagnosis, and you're really doing a very nice risk assessment and chronic disease management. That's the mindset that you need to be in, and that particularly Sally needs to be in, because she's not getting over this illness. She's going to need to manage this illness, and it is her illness, and you will need to engage her, and she'll probably need a team of people, including her therapist, to help engage in that activity. So based on our assessment of Sally, what do we have? We have recurring, early onset, major depressions. We have a family history that's chock full of significantly mentally ill individuals, several suicides, a mother who has an established bipolar 1 diagnosis, and she's had manic episodes that meet criteria for bipolar disorder. So she has bipolar 1 disorder, meaning she's had a manic episode. She is currently in a depression, a major depression, with some mixed features: the talkativeness, the distractibility, the tangentialness, the racing thoughts. It's depressed, but it's a little manic. And it took 13 years to get her from when she began to be ill until now. And that's tragic, incredibly tragic. So when you're treating bipolar disorder, here's a summary of what we're thinking about. So you're looking for efficacy, convenience, safety, tolerability, something that the patient will adhere to, because that's the way you get to a robust, sustained remission of symptoms. And it's only in that robust, sustained period of wellness that Salley has a chance to think clearly and plan clearly and move on with life. And that's what we want Salley to do. We want to alleviate depression, and we want to provide long-term mood stabilization, because life lived with an unstable mood is the life that she has. It's 8 years of college and 5 different majors and a risk of suicide and not knowing what you want to do with a degree in political science and a minor in art, and you're waiting tables. Bipolar disorder, unfortunately, in both psychiatric and non-psychiatric settings, is very poorly treated. In a couple of studies in the literature, the most commonly prescribed medication for an episode of bipolar depression is an antidepressant. And we know that antidepressants as monotherapy, and even antidepressants when combined with mood stabilizers, are not the appropriate treatment for bipolar depression. So there are treatments for acute mania, there are treatments for acute bipolar depression, and there are treatments that have been approved and are used for maintenance therapy. We're going to focus really on the acute depression and the maintenance aspect. And again, the unmet needs in the area of treatment of bipolar depression are treatments that are well tolerated and effective and are efficacious in the long haul, because the illness is a lifelong illness, at least in reference to the science that we have today. So here's a graph showing the first study of the first medication approved for bipolar depression, olanzapine, fluoxetine in combination. And again, significant separation from placebo beginning at about 2 weeks and lasting through the study of 8 weeks. Here's the second medication that was approved for bipolar depression, quetiapine, and again, 2 different studies, Boulder 1, Boulder 2, showing that doses of both 300 milligrams and 600 milligrams of quetiapine were effective and separated from placebo in treating bipolar depression. And again, because 600 milligrams of quetiapine yields more adverse effects than 300, you typically think about the antidepressant dose of quetiapine as 300 milligrams. Here's the most recent medication that's been approved for the treatment of bipolar depression, Lurasidone. And again, there's a monotherapy study. On the left-hand side of the graph is your MADRS scores compared to placebo, the Montgomery-Åsberg Depression Rating Scale. On the other side is the CGI, the Clinical Global Improvement for Bipolar Depression Severity Scale, basically showing that Lurasidone in monotherapy separates nicely from placebo in randomized controlled trials for the treatment of bipolar depression. Some additional therapy on Lurasidone monotherapy indicates that at 2 weeks, in a post-hoc analysis of the Lurasidone studies, you can typically tell when you've got a positive signal. And for that reason, when we are seeing people in active management of both major depressive disorder and bipolar disorder, we're seeing people about every 2 to 3 weeks, because there's typically an assessment and an action plan that needs to be instituted for that. The other thing that has been noticed for Lurasidone in studies is there were significant improvements in both depression severity and on secondary measures of anxiety and quality of life and functioning. And Lurasidone is a fairly well-tolerated medication for bipolar depression. Another nice thing about Lurasidone in the treatment of bipolar disorder is that since bipolar disorder treatment is very often polypharmacy, a rational polypharmacy, Lurasidone looks like a good combination with both lithium, a standard mood stabilizer, and divalproex, which is an antiepileptic, which is also a mood stabilizer. So you could add Lurasidone based on established literature to people who are already on maintenance therapy. So second-generation antipsychotics are being used more and more in the treatment of bipolar disorder, also as adjunctives for other conditions, and here's a list of potential warnings and precautions. And we want to draw your attention to the need to monitor for metabolic adverse effects. Remember I told you that when Salley started therapy, we got a metabolic panel and a lipid panel and a hemoglobin A1C, and we'll be monitoring that for her periodically to make sure that we are in the safety zone around metabolic or glycemic control for her. And the other is the potential for cognitive and motor impairment. Tardive dyskinesia is still an issue. It is less prevalent on the newer second-generation antipsychotics, but it is not absent on these drugs, and the full assessment, the proper assessment of anyone who's taken any kind of an antipsychotic, whether first or second generation, involves assessing and documenting for abnormal involuntary movements and evidence of dyskinesia every time you see them. So another way of looking at the efficacy, safety, tolerability equation is the number needed to treat and number needed to harm. I'm sure many of you are familiar with that way of analyzing controlled trials. We like for number needed to treat in a randomized trial to be less than 10. That helps identify an efficacious treatment. We like number needed to harm to be greater than 10. That helps us identify treatments that are more tolerable and more safe. And I would just point here, there's information for the olanzapine-fluoxetine combination, for quetiapine, for lamotrigine versus placebo. And again, lamotrigine is not FDA approved for bipolar depression, but there are a couple of positive studies in the literature, and so it is sometimes used by experienced clinicians in this illness. But I wanted to point out the Lurasidone data versus placebo with a number needed to treat of 5 and a number needed to harm in the low dose range, 20 to 60 milligrams per day, which is the dose range you'll usually use Lurasidone if you do. The number needed to harm for akathisia was 18, for extrapyramidal symptoms was 40, and for weight gain greater than 7% from baseline was 58. And then you have your adjunctive Lurasidone, meaning Lurasidone with lithium, Lurasidone with divalproex. There are your numbers there. So we talked about antidepressants and bipolar depression. We talked about and referenced a couple of times the fact that although they are often used in the treatment of bipolar depression, based on good scientific data from multiple studies, they're not effective. So we would like to move away from treating as first-order treatments, adding antidepressants to mood stabilizers or using antidepressants alone for people with bipolar depression. First of all, the potential risk would be it's not usually going to work. The second potential issue is it might make them worse. It might induce a manic episode, rapid cycling, other kinds of things. Now, there are a few people that might do well with an antidepressant added to a mood stabilizer or a couple of mood stabilizers. The illness can be challenging to diagnose, challenging to manage, and sometimes antidepressants can play a positive role. But when you're initiating treatment for bipolar depression, you want to use a specific evidence-based intervention, and that's not antidepressants alone or antidepressants combined with mood stabilizers. Salley came from a therapist. Therapy has an established benefit. Psychotherapy has an established benefit in bipolar depression. Social rhythm therapies, family therapies, cognitive behavioral therapies, particularly dialectic behavioral therapies. Therapy is as good as a pill in many studies. And so the therapy is going to be really important for Salley because she's had such pervasive mood disruptions early in her life that she's missed a lot of the milestones for maturing and developing into stable adulthood. So now we're back to Salley. We know about her illness, we know about her diagnosis, we know about her family history, and we've taken a look at treatment in a general kind of way. Now we have to match Sally's illness to a rational treatment strategy. And what do we know? Well, she has a history of significant manic episodes and hypomanic episodes that we are going to have to prevent. She is in a severe current depressive episode that's severe enough to require immediate specific therapy. She has high recurrent depressive episodes, and so we need prophylaxis, for prevention of depression. And there's no single pharmacologic agent that currently fills the entire prescription. So based on a nice view of Sally's illness, she's going to need more than one medication, more than one strategy. So here's what we did. We put her on lithium at a small dose, 900 milligrams a day. That's kind of low standard therapy. Last level she came in with when we were checking levels was 0.7 MEQ per liter. That's the low end of the therapeutic range. Her renal function, thyroid function was fine. That's for prevention of mania. Probably also has some prophylaxis against depression. But I want to sort of mention here part of the art of treatment. People with bipolar disorder live with very passionate emotions, and they live in their emotions. And if you don't understand that, you might push the levels of some of these medicines too high. So you can't mood stabilize someone like Salley with a high dose of lithium and her be comfortable, because she lives in her emotions, and her emotions are part of her authenticity. And so what you want is not to damp all of the emotional movement out. You want to put boundaries around the emotions. Lurasidone at 20 milligrams a day was used to treat acutely the bipolar depression, and she had no adverse metabolic changes in follow-up. We also used lamotrigine as an agent known to and approved for prevention of bipolar depression, and she continued with her psychotherapist, as we talked about. 6 months in, Sally's very stable, very happy, very pleased. If she takes her lithium without a meal, she remembers that you really should take lithium on a full stomach. That's just part of the rules around taking lithium. But the plan is, since she is now in what I would call a robust, sustained remission, a full functional remission, some people say, she's engaged in her psychotherapy, she's on 3 medications that are working well. After a year of stable euthymia, probably planning on discontinuing the Lurasidone and then looking at the lithium and lamotrigine and the psychotherapy as her maintenance strategy. So everything's a journey, okay, in diabetes care and hypertension care, in the care of the bipolar patient. Early identification of the bipolar disorder is critical to optimal treatment. Remember, she went 13 years improperly diagnosed, had several non-productive treatments. If she had been properly diagnosed 5 or 10 years earlier, perhaps some of these difficulties in college and this sort of erratic kind of life plans could have been avoided. The rational polypharmacy we've mentioned several times. We want to maximize efficacy, safety, and tolerability. And stable emotions promote thoughtful decisions and self-efficacy. And again, we want to use our medicines in a way that eliminates episodes, but allows these highly emotional, highly intelligent, and emotionally intelligent individuals to have that authentic range of emotions that they're going to be comfortable with. Otherwise, they won't participate in treatment because their emotions are part of who they are. The patient gets to set the agenda. It's their illness. It's their life. Our role as clinicians is to inform and to engage and to collaborate and to help get to get the goals the patient wants in the illness control. The therapeutic alliance is always patient-oriented, and psychotherapy is essential, I think, for a successful outcome because, as I've said a couple of times before, there's no wisdom in a pill. So I thank you and hope this has been very helpful.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerviewpress.com/BWE. This activity is supported by an educational grant from Sanovian Pharmaceuticals Incorporated.